for 3 minutes. Then after that, we'll see the case studies together. We do have a series of case studies that are around 6 for today. In the span of 2 hours, we'll finish those case studies together. So I give you 3 minutes, then discuss, just look at the cases by yourself, then we'll discuss at the end after 20 minutes later. Okay. Okay, who can take us through the case study? Any volunteer? Remember, active participation is very essential. If you don't actively involve, I'll just remove you the group so that you go and read other activities. So is there anyone who is going to take us through about the case studies? Any volunteer?
So what do you mean talk?
Sorry?
So what do you mean by talking or taking us through this case study?
You just normally, you have read the case studies, yes? Yeah, have you read? Yeah?
Yeah, I did.
Yeah, if so, you just normally briefly describe what were the case studies, Then try to attempt it normally, like the question, what sign and symptoms of neurotoxicity is AL is experienced? Yes. Focus only about the toxicity at the moment, regardless of the condition. Okay.
So basically, this is a 39-year-old woman with acute leukemia, lymphocytic leukemia. And
Okay.
then she has methotrexate. She's been taking methotrexate 3 grams per M2 IV once daily, and then cytarabine for 2 grams per M2 IV every 12 hours on 2 days, and 3 for 4 doses. And then as well, she's been taking vincristine 2 mg IV on days 1 and 8 for 2 doses, and then dexamethasone 2 mg orally daily for 5 days. And so the laboratory data is as follows. We have the white blood count, which is 100, 1,000, 100, 200, no, wait.
130,000.
1,000 cells.
Mhm.
And the neutrophils is 9%, and then the lymphocyte is 11%, and then the blastocytes is 80%. And then on the third day, she's confused, and then she had like difficulty performing a finger to nose neurologic examination. And on the 10th day, she's complaining of numbness in her hands and feet because she can move and everything. She can't feel anything. And then after that, the clinician adds to the notes that she has an eyelid lag and ectasia. And then she also complains of constipation. So basically, what are the signs and symptoms of the neurotoxicology of AL, and how should we give her, or how should we recommend a remedy for her future treatment, basically?
Okay, so what do you think about, is there any sign and symptoms of neurotoxicity from the patient?
Yeah, I think so.
What are those signs and symptoms?
Ataxia.
There is ataxia, yes, that is very important.
She's not able to do the finger to nose.
Yes, and the patient is unable to do neurological examination. Yes, Then any other?
Confusion.
Is there any confusion from the
Yeah.
patient?
Constipation.
No. Yes.
Constipation, yes.
Yeah. No confusion.
Confusion, where?
Yes. On day 3, AL
Okay.
is confused.
Okay, yes. That is also a sign of neurotoxicity. But remember, not only like if the leukemia is progressing through, if the leukemia is actually involving the brain, even confusion can occur. So unless we rule out whether there is CNS involvement of the leukemia or not, we can say the confusion is only due to medication. Yes, good observation. Then those are signs and symptoms of neurotoxicity.
Numbness.
Numbness, yes. There is actually numbness. This is meaning, those are examples of autonomic neuropathy. Then what do you say about the lab results? So is there any abnormalities in the lab results? I know you have not covered about leukemias, but for the context, for the sake of these case studies, we just normally look at it. If the lab value is normal, the lab data obtained on admission, are they normal?
I think she has a low white blood cell count.
Okay, the total WBC count, but this one, is it normal?
I think the 80% blasts.
Yeah, these 80% blasts those are immature blood cells. Remember, in case of hematological malignancy, such as leukemia, what will happen? there is a stem cell. Remember in the bone marrow differentiation we'll discuss, there is a stem cell and there is actually mature blood cells. So usually what will happen in case of leukemia, it will arrest differentiation or maturation to the normal cell. Because of this reason, the blast cell count is usually very high in case of leukemias, but those blast cells are not matured enough to work as a normal function. However, because of this reason, the normal blood cells are usually lower, but the blast cells are actually 80%. So in normal bone marrow, the blast cell is between, or it is less than 5%. So if the blast cell above 20% is actually a feature of leukemia. So that means this, if you get a bone marrow of above 25% from the bone marrow aspirate, you get this much amount of blood, what they call the blast cell, we can say the patient is having leukemia. But however, if the blast cell is actually less than 20%, but above 5%, we call it bone marrow dysplasia. I don't know whether you have encountered a diagnosis like this, but because we have not gone there, we have not gone to the oncology ward, it's very common. Sometimes you will get a scenario whereby the patient does not qualify to have leukemia because of the blast cell count. Like it can go between 50 to 20%. Then, but however, because of the blast cell is not qualified, we call it bone marrow dysplasia, or we call it bone marrow dysplastic syndrome. Those are the common diagnoses, especially, but the probability of progression to leukemia is very, very high. So when you look at the WBC count, are they normal?
No, the WBC count is really high.
It is really very high. So what occurs, what normally gives high WBC count is most likely the blast cells. You can imagine 80% of the blast in the bone marrow means mostly for the total, what is contributing for the total WBC count is what? The blast cell. So have you seen the neutrophil count? By the way, sometimes it is good to know the normal value in terms of percentage. What is the normal neutrophil count? It is between, like for the neutrophil, it is between 40 to 60%. Yeah, between 40 to 60% is the normal. But for the lymphocyte, it is between 20 to 40%. So you can see 9% is actually very significant neutropenia, and the lymphocyte count is actually is lower. So when you look at, by the way, if the WBC count, the total is very high, and if the neutrophil, if the differentials are actually very low, it will give you an idea there is significant amount of immature blast cell, because the neutrophils are count, the lymphocytes count are actually low. So if this value is very, very significantly very high, that means there is a lot of blast cell. So it is good to know, by the way, but in detail, I will come to leukemias. So you can see, you have mentioned about the possible neurotoxicity due to anti-cancer agents. But the next question is, what is the most likely offending agent to cause this neurotoxicity? So what are those drugs, or which drug is responsible for toxicity for this patient, like ataxia, numbness, even eyelid lag? What are those? Which drug is responsible? Okay, vincristine.
Yeah.
I think for the numbness, yeah, it's vincristine.
Okay, for the numbness, it is vincristine, yes, because vincristine or vincalcaloids, they can cause what? Autonomic peripheral neuropathy. Yes. Okay, good. Then what about the possibility of CNS toxicity with cytarabine and methotrexate? What do you think? Have you covered in pharmacology? Normally, I didn't mention very well because I'm assuming you are going to discuss in detail those things in pharmacology, because that is the point of discussion.
Sir, The fact that methotrexate can inhibit folic acid, can it be maybe something that can cause toxicity?
Yes, that is true. By the way, good observation. By the way, methotrexate, because of the effect on folic acid, it can actually even affect many toxicity. So the toxicity due to methotrexate is mainly because of folic acid. So the mucositis, those other even bone marrow suppression, those are as a result of depletion of folic acid. However, the moment you give folic acid rescue, you can actually restore. Yes, there is. Yes. What about cytarabine?
So
Yes.
can
Question.
can methotrexate also be a cause for confusion?
Yes, it can be. Yes. But I was wondering, have you covered normally what kind of toxicities can be occur because of cytarabine? It can cause several toxicities, especially if you give them those drugs at a dose of above 1 gram. If you give them methotrexate and cytarabine at a dose above 1 gram per meter square, the risk of CNS toxicity is very, very high. So, generally speaking, the neurotoxicity of this patient is due to methotrexate, cytarabine, and vincristine. So all of them are responsible to cause CNS toxicity in different doses. But this one is usually having dose-dependent toxicity. It has actually having this effect at a dose above 1 gram. So this summary is methotrexate have little or no neurotoxicity at a dose which is less than 1 gram per meter square. But however, you give them high dose, the probability of having encephalopathy is very, very high. Even for cytarabine, if you give them a dose above 1 gram per meter square, there is a possibility of CNS toxicity. That is why when you look at the doses for this patient, both of them are above 1 gram, so the risk of toxicity is very high. So the toxicity is actually because of multifactorial. So what is the most likely medication that causes numbness? I've already mentioned that the numbness for this drug, for this patient is due to vincristine. Generally, the patient should remember the patient on day 1 and day 8 of chemotherapy. So the probability of toxicity or numbness due to vincristine is usually very common within the first days to weeks of therapy. So that is why if you look at even if you look at the case studies, when that the patient developed those numbness, you can see she complains numbness in her hand and feet. So mostly they initiated on day 1 and day 8. Okay, vincristine 2 milligram IV on day 1 and day 8 for 2 doses. So that means like immediately after, the probability of having this toxicity is very, very high. Okay, then the next question is, what is the significance of Ellis lead lag? So what causes the lag of his eye or eyelid, sorry? Do you think it is related to with the drug toxicity or something different? What is your opinion?
I think if she didn't, on admission, if she didn't have it, it's probably caused by the drugs.
Normally from the history, they are thinking the patient does not have any problem before. She encounter like that problem after chemotherapy. So that means there is something which is responsible for this patient. So what is your observation? So as Bridget said, most likely it could be related to drug, but which drug is the most likely causative agent for this condition? Any trial?
Vincristine.
Yes, vincristine. Yes, why vincristine causes normally lag of the eyelid?
I don't know.
Okay, anyone? Maybe. Okay, we willing to answer. Victoria?
I don't know.
Are there any trial? Do you know? Okay,
Sir.
or okay, huh?
Does it cause a change in the thyroid hormone levels in any way?
Oh.
Because
Okay. Huh?
yeah.
Yeah. So you are thinking it could be because of vincristine increase the level of thyroid hormone and it causes hyperthyroidism and affected the eyelid.
Yeah, something like that.
Okay, okay, good observation. But when you look at the lag of the eyelid for this patient, yes, you tried, okay?
I think with the mode of action of vincristine, because it inhibits the action of tubulin, yeah? So it can interfere with the axonal function and then therefore cause a problem. Because if you see that lagging of the eyelids, it's because there's a problem with the nerves.
Yeah,
so
that is true.
I think the action of vincristine by interfering with the transport with axons, and that's what causes it.
Okay, good trial. I like normally the way you are linking what you have done so far with the possible toxicity of vincristine. Okay, good observation. Okay, but like that, okay, like for example, as you said, it is correct, but like paclitaxel, which is they are in the same, they are microtubule synthesis inhibitor, the probability of having neurotoxicity is very minimal, despite they do have the same mechanism of action. So I think there is something unique about vincristine, apart from the mechanism of action. Okay, good observation. Okay, do you know what? Do you know ptosis? What is ptosis? What do you understand from the image? I hope you have heard about ptosis. Huh? The eyelid is actually dropped because there is a palsy of the nerve that controls the movement of the eyelid. So they cannot actually like move up the eyelid. Can you see normally the image on the right side? You can see like ptosis in adult and ptosis in children, yes. So which cranial nerve is responsible to control the movement of the eyelid? So which cranial nerve?
The optic nerve.
Optic nerve, okay, good. Optic nerve is mainly for vision. It does not control the movement of the eye.
Is it the oculomotor nerve? Is it the oculomotor nerve?
Oculomotor, yes. Oculomotor nerve is the one that controls the movement of the eyelid. By the way, when I'm actually reading the question, you just try to explore the information, yes. You Google it, then you give us the answer. Because it's just like this question, it's not an exam. So cranial nerve 3, which is known as oculomotor nerve, is the one that controls the movement of the eyelid. If someone is actually having palsy or damage of this cranial nerve, the probability of having ptosis is very high. I don't know whether you have encountered this problem. Personally, I've seen one case, like in my life so far. Like, so I've seen only one case of ptosis. But so when you see like one eye is dropped, one eyelid is actually dropped, means the probability of having that damage of that cranial nerve is very high. Then, so from this, the eyelid lag is related to damage of the oculomotor nerve. So the justification is cranial toxicity occurs in 1 to 10% of the patient who is receiving Vilca alkaloids. So probably most patients present us with ptosis probably related to the damage of the third cranial nerve. So most likely, the ideal lag probably is caused by the vincristine associated with the damage of cranial nerve number 3. Okay, so you have to like expand your thinking when you are looking the toxicity of the drugs. So that is why you need to know the property of the drugs, especially in terms of toxicity. Anti-cancer agents normally require due consideration because they are cytotoxic in nature. Then, what is the cause of endless constipation? I think someone has already answered what causes constipation in this patient. If you know what causes, then how do we prevent constipation in this patient population? Kultum.
Hi, sir. Please repeat the question. I didn't hear.
Yeah, you can read even from the slide. It says, what is the cause of AL as constipation? Yeah, from the history after chemotherapy, the patient developed constipation, and we are thinking it is a drug that causes constipation. So what the first question is, what is the cause of the constipation? And secondly, how might this problem can be prevented?
So I think to prevent constipation is probably changing the diet.
Which diet?
The to have more fiber in their diet.
Such as?
Pardon?
Such as? Which diet is rich in fiber?
More greens and avoid potatoes and stuff.
Okay.
And then the causes of chemo is from the medication that they're taking, right?
Yes.
But I can't tell you what medication exactly.
Yeah, maybe I think you joined recently, yes? Or maybe you
I
are
joined
doing something.
at 140.
Oh, okay. That is why, yeah? Okay,
Yeah.
good. Any other trial, yes?
You give laxative.
Yes, you can give laxatives. But what is the etiology, Morgan?
The etiology.
Yeah, what causes normally the constipation for this patient?
It's the autonomic neuropathy caused by vincristine.
Yes, it is actually the autonomic neuropathy that is caused by vincristine. So, as you said, the best way to prevent constipation for vincristine class of drugs is usually prophylactic laxative should be given. But then in most of the circumstances, if a patient is actually having taking Vinca class of alkaloids, they usually give prophylaxis laxatives, like maybe bisacodyl, which is the most commonly available, but it can use any other types of laxatives. Okay, good. So Vinca class of alkaloids, they can cause autonomic neuropathy such as constipation. Then second case, read for 2 minutes. Okay, now let us do it together. Is there any volunteer who is going to take us through the briefing of the cases? Any volunteer?
So I can do it.
Okay, please.
Okay, so DA is a 35-year-old man with stage 4 Hodgkin's disease and is receiving a BD, which is doxorubicin, 25 milligrams and IV, and then bleomycin, 10 units, and then on days 1, and then 15 vinblastine, 6 milligrams on day 1, 15, and day 1 and 15, and then dacarbazine, 375 milligrams on day 1 and 15 also. So he's also receiving radiation concurrently for the large mediastinal mass, and he comes to the clinic for the 5th cycle of ABVD and complains of tachycardia, SOB, and productive cough. And then under the physical examination, he shows that he has neck vein distension, pulmonary rales, and ankle edema. In his past medical history, we've seen he's been controlled for hypertension before. So the question is trying to find out what is most likely to cause the current symptoms.
What do you think? Is it drug related or is it just because of his past medical history of significant controlled hypertension? So based on your observation,
I think it's drug related, especially because of doxorubicin. Doxorubicin causes dose-dependent cardiomyopathy, and I think the dose might be a bit too high in this one.
Okay. So how do you came up with this conclusion? Like the most likely agent is drug related and caused by doxorubicin?
Okay, from what you've studied, doxorubicin causes cardiomyopathy, and then I think from also the regimens that you gave us, usually the standard dose for doxorubicin is not 25 mg. It's about it's less than that. I can't remember exactly what it is, but it's less than that.
No, it is above even that, by the way. It is just for lymphoma. We are using, otherwise it is 60. Like for the breast cancer, we are using 60 milligram per meter square. Thank you so much. Yes.
Sir?
So what is your basis?
Doxorubicin causes congestive heart failure. So here the tachycardia, the shortness of breath, and the non-productive cough, congestive heart failure also presents with this. But then also maybe another question, there could also maybe be pulmonary toxicity. I don't know, maybe because of the pulmonary, also the edema is a sign of congestive heart failure, but also bleomycin causes pulmonary toxicity. So maybe those two are the question. Yes.
Can be both, yeah? Okay. Okay, good observation. Thank you so much. Then you have seen the patient is having pulmonary features and cardiac feature. But when you look at the condition, the patient is actually having pulmonary toxicity as well as like an edema. Those edema, especially in the peripheral system and neck vein distension, they are an indicator of there's a cardiac damage. So it does not cause, like bleomycin can cause all condition at the same time. But as Bridget said, it can be both, but the most likely agent will be probably, remember when you say most likely, what is the most likely causes? We are not very sure what exactly causes that problem, but we are actually narrowing our selection. The most likely agent to cause this problem could be doxorubicin. But why? Because if you see even when you look at the toxicity, the patient was okay when he was taking the first cycle, second cycle, third cycle, and fourth cycle. but the patient complained those symptoms when the patient started when the patient started the 5th cycle. This will give you an idea. This toxicity is related to cumulative dose toxicity. So that means most likely this cumulative dose related toxicity is related to doxorubicin. But also bleomycin, the side effect is actually still cumulative dose toxicities, that it is very unlikely to produce all those clinical pictures at the same time. By the way, meanwhile, this is the most commonly used treatment for Hodgkin's lymphoma locally. Like if you go to the protocol for Hodgkin's lymphoma, you will see ABVD. Some oncologists even they don't even write the full name of the drugs because the doses are standard. Like doxorubicin 25, bleomycin 10 unit. The unit of measurement for bleomycin is unit. Then for vinblastine 6 milligram and the carbazine is 375 milligram. So those are standard protocol, yes, in concurrent with radiation therapy. But we'll discuss more while we're discussing about lymphoma. But don't you think this condition can be caused by the hypertension? Because hypertension is actually one of the causes of heart failure. So how do you come up with this conclusion? This condition is actually related to the drug, not the other cardiovascular condition. Is there anyone can try?
So the case study says that prior to this, the hypertension was controlled.
Okay,
So,
good, exactly.
yeah.
Huh? So prior to that, the medical condition, the control, as long as the BP was well controlled, the probability of causing heart failure is very minimal. Of course, hypertension can actually cause heart failure because it can increase ventricular hypertrophy. So if the ventricle undergo hypertrophy, it is beyond the capacity. So when there is a change in size of the ventricle, they cannot effectively pump blood to meet the metabolic demand. Okay, good. Now,
Sir,
okay,
I have a question.
Okay.
The radiation, is it directed at the chest? And if it is, can it cause some of the symptoms?
Sorry?
The radiotherapy.
Yeah, the
Is it
radiotherapy.
directed at the body? Is it at the chest?
No. By the way, okay. Normally, my intention was just to take you through only the toxicity. But if you ask the question, the patient is actually having a mass in the mediastinal area. Remember, the mediastinal area is normally around the breastbone. Eh? Do you know where is the breastbone? The location of just between the head and head. So at the middle, there is the breastbone. So that area is known as mediastinal area, especially between the lung and the heart. So which is very common. This mass is very common, especially in lymphoma patients. So that is why they are actually radiating that mass. They are actually radiating that mass. So of course, there is a possibility of local damage around the lung, which is responsible maybe for shortness of breath and non-productive cough. But as I mentioned before, the most likely cause will be doxorubicin. But as Bridget said, it can even be bleomycin because of pulmonary features. But also, the radiation therapy can cause local damage and produces some pulmonary dysfunction, which is true. But radiation is very unlikely to cause edema in the lower extremities, which is typical features for heart failure individuals. Okay, did they answer your question?
Yes.
Okay, good. Any other issues? Okay. Now, let me take you through the next question. So, do you think there is a need of... Yes.
Before giving the drugs for this patient, by the fact that he is a hypertensive patient, before they give doxorubicin, they have to do tests to make sure that your heart can be able to maybe won't be so like it's not you don't have heart failure first before they give doxorubicin. So can we also say that shows that probably the hypertension was controlled, so it can't be the cause of the heart failure?
Yeah, that is true by the way, because we are expecting if the BP was controlled, the probability of having end organ damage is very minimal. So as you said, before you initiate doxorubicin, cardiac function test is very essential, so that you can be very sure, for accuracy of the treatment. But the problem, Bridget, this treatment related to cancer is very, very expensive. How much you are very rich, it's at some point normally it will challenge you, especially you can consider like how many people are actually can afford the treatment. So that is why sometimes they don't do all the lab tests they are supposed to do because of financial constraints to the patient. Otherwise, it is really good. Do monitoring before you initiate yes, then calculate the cumulative dose. That is the role of the pharmacist, by the way. In KNH, it is a pharmacist who is usually tracking. So I think there is one experience I have seen in KNH only. In KNH, in the oncology pharmacy, you will get the patient files. So before the chemo, the pharmacist will receive the prescription, that is the chemo sheet, and the medical record of the patient. So before then they will assess every individual. They look at every aspect of the patient. Then now, after that, they can actually even consider or dispense or do the chemo mixing in the room before administration. So this is something unique I have seen. So they got the opportunity to go through, and they're actually even allowed to do any correction. But of course, it should be in consultation with the oncologist. So this is something I have seen, like it is really good. So when you go to the oncology, you don't see only the sheet. You will see also the patient files. So they have to check many things. So because of that reason, in the oncology, they do have many activities. Maybe some of you, if you are interested to work in oncology areas, do your attachment in KNH. Once everything is settled, like after this COVID era, once you start the attachment, just apply. Like one student normally did in KNH, and she really enjoyed it. So it is really a good opportunity even like in the future. So do that, then you will see at least or the whole aspect of like KNH, how intensive it is. Then you will see actually even some unique condition. And I really appreciate if you apply, some of you. Okay, good. Then, as Bridget said, there is a need of monitoring for this patient, especially when they're receiving doxorubicin. In fact, the patient is also having risk factor, that is hypertension. So, especially for such a scenario, we need to consider monitoring. Then now, how do you, now the patient has already developed heart failure. So how do we manage these patients' heart failure? How do we manage? What is your opinion?
You withdraw the drug.
Yes. Yes, remove the drug, discontinue. Yes, that is one possible strategy. Good.
So there's a drug that can be administered with doxorubicin from the same class. I don't remember the name, but it's something dextrozone or something.
Dextrazoxane, yes. But you're right, by the way, Bridget, and thank you so much for reminding me this one. But we'll discuss more about the antidote of anti-cancer treatment. But this one is usually useful for acute toxicity. The moment you give them the drug, Then if the patient developed toxicity immediately, now you give them antidote. But this one, remember, the patient developed heart failure after 5 cycles of chemotherapy. Now they do have clinically diagnosed heart failure. So do you think the heart failure can be reversed by giving that antidote? Yeah, there might be some improvement, but the patient is already, the heart is already failed, and heart failure is just reversible. Once it is failed, you can't reverse, but you can prevent the progression. Good observation.
So maybe you can incorporate drugs that can treat the failure, the heart failure.
Such as?
Beta blockers.
Beta blocker, from beta blocker, which one is approved?
Carvedilol.
Yeah, at least you don't forget carvedilol, because that is the most commonly used drug in Kenya. The regimen in heart failure, but it is not the only drug. Metoprolol is also used. Okay, good. Any other? Any other?
The assignment we did is the low molecular weight heparin. Can it be used?
The low molecular, no, that one is just recently approved. I don't know, what was your finding? Yeah? In fact, some of you didn't even do proper investigation when you are doing the review. I've seen it's only 1 or 2 individuals. I really impressed the way they normally put the information. It's only 1 or 2. Yes, from the whole 50 something students. Okay. So that one has not yet approved, because even the study was reported recently. So they just normally find out enoxaparin has some effect to reduce current toxicity due to. Yes. Okay, good. But the heart is already failed. But as Titania said, we need to introduce heart failure regimen. If you remember what we have discussed in this semester last year, in the same semester last year, heart failure can be caused by different conditions. One is drug-induced. If it is whatever the cause of heart failure, if the heart is failed, the treatment is the same. So we still use the same regimen that can be the same regimen, like the same regimen what has been used before in the management of heart failure. So as someone said, discontinue promptly. Then after that, of course, we use the AC inhibitors, the ARBs, and diuretics. In fact, this patient is having edema, and even the patient is coughing. So most likely it is because of pulmonary edema. So even diuretics are very, very, very important. So we still use the same protocol for heart failure management, what we have seen in other conditions. So the protocol is similar. Then, question.
A question. Would you still use diuretics in the absence of edema?
No. In heart failure, no, not really. Because the primary treatment for heart failures are beta blockers and ACE inhibitor. We call them neurohormonal blocking agent. Remember, in heart failure, when the heart is failed, there is activation of the compensatory mechanism. RAS system will be activated, sympathetic nerve system will be activated, so they can exacerbate the heart failure because they can cause cardiac remodeling. So to reduce the progression, you have to introduce ACE inhibitors or ARBs and beta blocker. If there is an edema, that is in acute decompensated heart failure, that is where we are going to introduce diuretics. Otherwise, diuretics are not the primary treatment in heart failure management. Good observation. Any other? We can proceed, yes? Okay. Now read the case studies for 2 minutes. then we'll do together. Okay, let us do it together. Maybe let me, is there any volunteer first? Any volunteer to take us through? Yes, briefly. You are not supposed to read like everything. Just normally like brief us. Where is, maybe Susan, can you try?
Okay.
Okay, thank you.
We have TJ, a 58-year-old man. He has head and neck cancer, which is non-resectable, so he's being treated with cisplatin on day 1, a dose of 100 milligram per meter squared, and chlorouracil for day 1 to 4. And he receives normal saline before and after his cisplatin. And he presents for his 3rd cycle regimen, and they do a urine analysis for creatinine, and it reveals that his creatinine clearance has dropped from 110 ml per minute to 75 ml per minute. And other abnormalities they see is serum magnesium level of 1.2 milliequivalent per liter, and everything else is normal. So they want that is cisplatin responsible for the decreased GFR rate and serum magnesium levels.
So, and give us your opinion. But do you think it is related to the cisplatin or it's why?
I think it may be related, but we see here they took precautions of giving him normal saline, which is hydration, which helps prevent the damage to the kidney. I'm not sure.
Okay, by the way, despite you give them sometimes even, remember the dose the patient is taking, it is just high dose of cisplatin, so still it can reduce, but it's one mechanism of prevention and good. So what is the mechanism of toxicity of cisplatin? Okay, huh?
I was thinking, doesn't cisplatin cause nephrotoxicity? So in that, it affects the absorption of magnesium in the loop of Hanle and ascending limb. I mean, in the distal tubule. That's why there is low levels of magnesium.
Okay, exactly. Yes. Good. Now you are right like so. Remember, the toxicity of cisplatin is nephrotoxicity, but this nephrotoxicity is characterized by especially electrolyte disturbance. But the cisplatin can cause hypokalemia and even low level of magnesium, that is hypomagnesemia, because cisplatin can actually affect the proximal renal tubule, which is very important for the absorption of electrolyte. Because of this reason, despite they give them even supplement, so most of the time there is a possibility of hypokalemia, and hypomagnesemia is very common because of loss. That is how cisplatin causes toxicity. Even it is very easier to monitor by assessing the potassium level and the magnesium level, so that you can find out whether there is renal damage or not. So it is linked to the drug, and also because of nephrotoxicity or damage of the glomerulus, there is a possibility of reduction in the creatine clearance. So remember, the patient has already hydrated. Okay, let me ask another person. Then who? Hafsa. Hafsa, can you hear?
Yes, sir.
Okay, so why normal saline was given for this patient? If you can see from the case, 1 liter before and 1 liter after his cisplatin administration on day 1. What do you think? Okay, any other? Okay, why it is given? Any other? Any other person?
So it's to decrease the possibility of nephrotoxicity by decreasing the concentration.
Okay, exactly. It is just normally to reduce nephrotoxicity. So one strategy is normally hydrate the patient before chemotherapy, which is very important. So you have adequate perfusion. Then we have answered the case studies. Then let us see the next case study. The next question is about toxicity of even anti-cancer drugs. So you just read for 2 minutes, then we will discuss it together. Then Sandra will take us through after 2 minutes. Okay, Sandra, take us through, please.
JA, a 54-year-old man was with stage 3 Hodgkin's disease, has received ABVD, which is doxorubicin 25 mg per meter squared IV for day 1 to 15, bleomycin 10 units per meter squared IV for day 1 to 15 as well, vinblastine 6 mg per meter squared IV for day 1 and 15, and dacarbazine 375 mg per meter squared IV on days 1 and 15 for 6 cycles. He presents to the clinic 6 months after his last cycle with dyspnea, non-productive cough and fever. Chest radiograph shows diffuse bilateral infiltrates. His respiratory rate was 36 breaths per minute. And his arterial blood gases were pH of 7.5, PO2 of 62 mmHg, PCO2 28 mmHg, and oxygen saturation of 92%. So the question is, what are the possible causes of his new pulmonary finding?
Okay, so what do you think? What is the possible cause of his new pulmonary findings?
I have no idea, but I guess it has something related to his disease because he's in stage 3. So I guess his immunity is compromised or something, but I don't know.
Okay, yeah, there is a possibility. Maybe his immunity is compromised and he developed even pneumonia. Yes, there is one possibility. Any other? Any other? What causes normally? What are the possible causes of his new pulmonary findings?
Bleomycin.
Yes, it can be bleomycin because remember, initially, okay, why bleomycin, Patel? Let me hear from you first.
One of the toxicity is pulmonary toxicity.
Yes, yes, it is
bleomycin.
pulmonary toxicity. And apart from that, pulmonary toxicity usually comes as a result of cumulative dose, and it usually presents like 6 months after his last cycle of chemotherapy. So you can see there is a possibility of bleomycin because of accumulation. Yeah, because they actually have this problem, not initially. Okay, good. Then how do you see normally his blood gas analysis? pH of 7.5, partial pressure of oxygen, TC2, PCO2 28, saturation 90. Are they normal? Can you interpret, please? Is there anyone who is willing to give us the interpretation? Ezra or Isron has already said something before. Okay, maybe let me, immaculate, yes. Immaculate.
Pardon?
Okay, what do you think? Can you interpret the acid-base balance for this patient?
I'm not sure.
Is there anyone who is willing to give us the interpretation? Sharia, try.
So I think the pH is a bit high.
So it is alkalosis?
Yeah. And then for oxygen, the partial pressure is low.
Okay, the oxygen partial pressure is low, yes. What is the normal value?
I think somewhere between 75 to 100, if I'm not wrong.
Yes, you are right. It is just between this level. Good. Then partial pressure of carbon dioxide?
It's low. It's around 40.
Yeah, the normal value is 35 to 45. What about the oxygen saturation?
I think I don't know about that one.
Yeah, the oxygen saturation, the normal is above 95%. Yes. Okay, good. So based on this result, what do you call, what kind of acid-base disturbance the patient will have?
So is it alkalosis, pulmonary alkalosis?
Yeah, it is normally respiratory alkalosis. Why?
Because of how we've just gone through the values, like the pH is too high.
That is alkalosis.
Yeah, partial pressure of carbon dioxide is low. If
Yes.
it was acidosis, it would have been too high.
Yes.
Yeah, and then also the oxygen saturation being low. I think that all points towards
Respiratory
pulmonary
problem.
disturbance.
Okay, that is true. By the way, this patient will most probably have respiratory alkalosis. Yeah, because you look at the pH, if the partial pressure of carbon dioxide. In fact, in order to interpret fully, we need to have the bicarbonate level. But anyways, based on these values and the clinical picture of the patient, most likely the patient is having respiratory alkalosis. So the possible causes you have already mentioned, it could be the drug, it could be the disease condition. Then have you seen normally the chest infiltrators? Those chest infiltrators are actually could be a sign of infection. Like in case of pneumonia, you will see those infiltrators. Those are inflammatory mediators, then infectious cells. So you will see. So those are that can be done in using chest radiograph. Okay, so apart from that, the patient is actually having increased risk of infection. So the patient can be having pneumonia. Remember, even the patient is also having fever. So this fever is maybe as a result of an infection in ways. It could be even a relapse of his disease. Remember, okay, lymphoma can cause by the fever. That one I will discuss later. Like cough, fever, those are cardinal signs and symptoms of even Hodgkin's lymphoma. So most likely it could be the drug, it could be the immune system, it could be even the treatment, as you said, could be like bleomycin, which is responsible for that condition. Then
So I have
this
a question.
Okay.
Sorry. How do you know if the person, like the difference between relapse of his disease and the infection?
Oh, sorry, relapse and what?
And if he has an infection, because you said it's either he has an infection or he has a relapse of Hodgkin's.
Yeah, but by the way, that is a good question. We do have tumor markers normally to assess whether the patient is actually having a relapse or not. The first thing, especially in lymphoma, I just normally just hold the information because we have not covered lymphomas. For example, in lymphomas, you can see the lactate dehydrogenase level. So usually, the lactate dehydrogenase level is very important to monitor. Then, of course, you can even see the size of the tumor. Lymphoma is, by the way, one solid type of hematological malignancies. You will see normally a tumor. So if the tumor was initially shrinked the moment you give chemotherapy, then maybe a few years later, if the tumor came back again, we can say this is just a relapse. And apart from that, you can even look at the LDH level. Of course, you can also see hematological parameters. Is there any improvement in the lymphocyte count? Is there any reduction in the lactate dehydrogenase level? So you can easily know normally whether it is an infection or not by assessing other tumor marker parameters. But that one, you just hold the information until we discuss. Okay, any other issues? Okay. Okay, now you read this one for 1 minute. So I think for this one, we're not supposed to spend a long time. Maybe one person even can answer. Morgan, can you try? So they have done everything. There is negative for microorganisms. Biopsy shows inflammation and fibrosis, but there is no evidence of lymphoma. Even, by the way, biopsy is also another thing. By the way, sometimes they do biopsy even to check whether there is a tumor or not after treatment to monitor the response. So there is no evidence of lymphoma. Yes. So that means it is highly related to the pulmonary damage, and the agent that is most likely causing this toxicity is bleomycin for the above patient. Okay. Then how do we treat this JS agent-induced pulmonary toxicity? So how do we treat the toxicity as a result of bleomycin in this patient? Is there any volunteer who is willing to try?
So maybe we can start by either reducing or withdrawing the drug.
Yes, yeah, but mostly withdrawal of the drug will work best because of the patient condition, especially in lung fibrosis. You just dose reduction might not be an effective strategy. Is dose offending agent? Good. Is there any other strategy? Do you think any other possible strategies? Okay. The most effective management of drug-induced pulmonary toxicity is prevention. So if we know normally the toxic agent, we need to discontinue immediately. Of course, if there is pulmonary infiltrates, example infection such as pneumonia, you have to treat. But quite often, pulmonary toxicity is reversible and progressive, and there is no available effective treatment. But of course, we can use even the steroids can be administered in case if there is hypersensitivity associated pulmonary damage. So the only way we can prevent is normally withdraw the medication, treat the infection. If the patient is having pneumonia, then you can consider even the use of steroids. Otherwise, there is no effective treatment available to treat drug-induced toxicity. Then, because of time constraint, I didn't normally talk about the effect of or the prospects of fertility after chemotherapy. Maybe that is why I just decided normally to give you a brief overview of the possibility of fertility, or are there any possible effect of is there any probability of the fertility can be affected as a result of chemotherapy. So you just read the case study for 2 minutes, then we'll see what is the prospect of fertility after chemotherapy. Is there a possibility of permanent ovarian failure? Is there a possibility of permanent infertility? Is there a way fertility can be reversed? So is there a way teratogenicity can be happen after chemotherapy? So in the next few minutes, we'll discuss those things and we'll finish for the session for today. Okay, read for 2 minutes. Okay. Now, what do you think? What do you think? Is there a possibility for this person to conceive after chemotherapy? So what do you think?
The possibility isn't very good.
Okay, good. Why?
Well, with cyclophosphamide in particular, it's known to cause infertility because it's not it's a non-specific chemotherapeutic agent, so it has cytotoxic effects on our basically almost all the cells in the body, including the gonads.
Okay, thank you so much, Shawa. That is good. So the prospects of fertility, is there any other different opinion or any supplement? Where is Yusuf today? Okay, continue.
Radiation, can it cause infertility, especially if it's external?
Yes, but usually it will cause infertility if you are radiating around the pelvic areas, around that ovary for cervical cancer treatment mainly, or maybe either any uterine cancer or even vaginal cancer, there is a possibility. But in other parts, if you are radiating the breast, the probability of having a damage to the lower extremities, that is the pelvic areas, is very, very unlikely. Otherwise, it has still a potential to cause infertility too. Okay, good. So is there any other opinion? Any other opinion? Okay, fine. So let me take you through about the possibility of gonadotoxicity as a result of chemotherapy. So cytotoxic chemotherapies is potentially gonadotoxic to the human being. So studies from the ovarian biopsy showed that those chemotherapy treated women for a cancer demonstrate loss of ova and follicular elements. In case, especially if the toxicity is severe and prolonged, there is a possibility of even permanent ovarian failure can occur. But in some individuals, there is a possibility of recovery, but it will take a long time to recover, to resume its normal cycle of ovulation. But if the ova are spared and follicular cells are recovered sufficiently, ovulation and pregnancy can occur. But however, most cytotoxic agents, specifically alkylating agents, are the most potent gonadotoxic agents. As Shava said, especially cyclophosphamide is well known for producing infertility in men and women. So you can actually even see the prospect of infertility or prospect of fertility for CL is very, very minimal because she is taking the most gonadotoxic alkylating agent, which is cyclophosphamide. But however, the influence of toxicity varies the total dose of cyclophosphamide in the age of the patient at the onset of chemotherapy. Like if someone is taking at the age of 20 years, the probability of amenorrhea will occur after a total dose of 20 to 50 grams. But the same consequence of amenorrhea can actually occur if a patient is taking this dose, if they are above 35, if they are above 40, they actually, even a small dose of cyclophosphamide can increase the risk of amenorrhea. So depending on the exact dose of cyclophosphamide in the ACT regimen plan, CL may or may not fall into a dose range that would be expected to produce permanent amenorrhea. So remember, the higher the doses, the higher probability to cause permanent amenorrhea. So the chances are actually depending on the dose. But apart from that, this patient is actually taking also doxorubicin. So there is a synergistic gonadotropic toxicity has been reported with doxorubicin with cyclophosphamide. So you can actually even see the patient is actually taking highly gonadotoxic agent. Then also she is taking doxorubicin, which some combination has synergistic effect. So we can actually even say the prospect can be even minimal, especially if the total dose of cyclophosphamide for this patient is very high. We can see the prospect of fertility is very, very minimal in the future for this patient. So remember, aside from alkylating agent, these agents are also gonadotoxic. The vinblastine, etoposide, cisplatin. So they do have high risk of causing gonadotoxicity. So in case the patient can, as I said before, the patient can recover. Also, they might have permanent amenorrhea. But however, if they recover from chemotherapy-induced amenorrhea, it will take even years after completion of a therapy. So you need to advise the patient properly before you initiate the chemotherapy. There is low prospect. That means there is like permanent infertility. And if there is a possibility of recovery, there is actually, it will take some time to resume. So like proper counseling for the patient is very, very important. So because of that reason, CL should be counseled to practice birth control while receiving chemotherapy. Why? Because those anti-cancer agents, they can even cause mutation and ultimately causes teratogenicity to the offspring. Because oral contraceptives are contraindicated for this patient, maybe we need to advise the non-hormonal methods can be considered for this patient. Then now, let me take you through about the effect of anti-cancer treatment on spermatogenesis. Remember, anti-cancer agents, they can affect the ovary as well as they can affect spermatogenesis. So this patient was recently diagnosed with testicular cancer, while cancer will receive systemic chemotherapy with bleomycin, etoposide, and cisplatin. What effect does systemic chemotherapy have on male gonadal function? So especially in terms of in men, the major toxicity of chemotherapy in men is loss of reproductive capacity. So during treatment, they can actually reduce the sexual desire as well as activity can be declined. But most men report there is a return after completion of treatment. But however, there is a possibility of marked reduction in testicular volume and there is a possibility of azoospermia, like the sperm count can be actually 0 or there is no sperm. Azoospermia means there is no sperm on the semen. Then of those cytotoxic chemotherapeutic agents, alkylating agents are still the most notorious in terms of affecting spermatogenesis. So you can see even dose-related oligospermia can occur if a patient is taking all those medications. Those are alkylating agents. But also doxorubicin, vinblastine, even cisplatin can actually cause risk of azoospermia. So you can see the patient is taking, from the case study, the patient is taking etoposide, yes, cisplatin. Those are some of the agents. They can cause what? They can cause azoospermia. Then phase-specific agents such as antimetabolites and vincal, it seems they are very unlikely to produce azoospermia, but when they are combined, they do have some role, but they are not as such as compared to alkylate agent. But as I said before, there is a possibility of recovery is usually very long. But then comparatively, the rate of recovery is very high in men as compared to female, because this spermatogenesis process is continuous throughout the life of the individual. But however, it usually takes at least 2 to 3 years to recover. Yes, that is why you need to give them proper advice for the patient. The possibility of actually full restoration will take a long period of time. Then apart from that, azoospermia has been observed in 35% of patients receiving ABVD, and spermatogenesis nearly always recovered in those patients. So ABVD, despite it causes this problem, most patients are usually recover. Then, if JK regains fertility after his planned combination chemotherapy regimen, is he at risk of producing offspring with congenital abnormalities or an increased risk of cancer? So what do you think? JK, the cases we have seen here, you're supposed to receive those combination therapy for testicular cancer. So do you think there is a possibility of congenital abnormalities in the offspring? Do you expect any possible teratogenicity to the offspring after chemotherapy for this patient? Any volunteer? Who is the name iPhone? Is there anyone? Okay, fine. So you can actually even see most of the agents we are using in treatment of cancer, they are interfering DNA synthesis, cellular metabolism, and division. So because of this, they may cause mutation of ova or spermatocyte exposed to those effects. Because of this reason, there is highest incidence of teratogenicity after chemotherapy. So generally speaking, men and women should be discouraged from conception during chemotherapy. In general, adults surviving cancer should advise to wait at least for 2 years after completion of therapy before attempting to parent a child. So this theoretically allows time for elimination of damaged germ cells. So the whole idea is there is a possibility of teratogenicity because the ova and the spermatocyte undergo mutation so that they can transfer, they can actually increase risk of teratogenicity. So because of that reason, at least for 2 to 3 years until the recovery of the damaged cell, the patient is supposed to wait to be a parent to reduce the risk of teratogenicity. So this is how some anti-cancer drugs, especially the alkylating agents, are teratogenic in nature. These are given for both men and women. So I think this is what I have for